Welcome to the Smart OB-Med curriculum. Social media for advancing residency training in obstetric medicine. We here present to you a national collaboration between the Universities of Ottawa and Alberta. This research project has been generously funded by the Department of Medicine at the Montfort Hospital, empowering future physicians in the care of medically complex pregnancies. We hope you will enjoy it.
Welcome to this module on hypertensive disorders of pregnancy. To start, it is important to understand the physiological changes affecting blood pressure during pregnancy, whereby both systolic and diastolic values decrease slightly in the first half of pregnancy, and later gradually increase into the third trimester. Chronic hypertension can therefore be masked in the first half of pregnancy, and patients on medications for chronic hypertension may need reduced doses of medications to keep their blood pressure under control. This figure illustrates these physiological changes with a slight dip in systolic and diastolic blood pressure around the 18th week gestation. Hypertension in pregnancy is classified according to this flow diagram, where blood pressure above 140/90 before 20 weeks gestation is pre-pregnancy or pre-existing or chronic hypertension, and that diagnosed beyond the 20-week mark as a hypertensive disorder of pregnancy. If there is no end organ damage, then it is gestational hypertension, whereas if there is target organ involvement, it is defined as preeclampsia. Preeclampsia can be non-severe or occur as a severe form, including HELLP syndrome and eclampsia. A blood pressure of 160 systolic or more, and or a diastolic blood pressure of 110 or more, is defined as severe hypertension, and at these blood pressure levels there is a significant danger for intracranial events such as ischemic and hemorrhagic stroke. Hypertension Canada recommends a blood pressure target below 140/90 or a diastolic blood pressure of 85 based on the 2016 CHIPS study. The 2022 CHAP trial confirmed the safety of this target in patients with chronic hypertension during pregnancy. The Hypertension Canada 2018 guidelines recommend starting a single antihypertensive agent when the blood pressure is 140/90 or higher, but less than 160/110. Targeting a diastolic blood pressure of 85. Regular follow-up should ensue. If the diastolic blood pressure remains at 85 or higher, then optimization of the antihypertensive regimen is recommended until that target is achieved. If the blood pressure reaches 160/110 or higher, then this is an obstetrical emergency. We will discuss the treatment of this in a later slide. Agents that are recommended for non-severe hypertension with systolic blood pressure between 140 and 159 over a diastolic blood pressure between 90 and 109 include methyldopa, which can be prescribed
Up to 2.5 grams per day.
Labetalol can be used up to 1,200 milligrams per day. Nifedipine XL can be used up to 120 milligrams per day. And rarely other beta blockers can be considered, although atenolol is contraindicated due to its proven effects on fetal growth restriction. This slide shows the first-line agents used to treat hypertensive disorders of pregnancy for non-urgent control of hypertension. Labetalol can be started at a low dose of 100 milligrams TID and can be gradually increased to target up to 400 milligrams TID. Labetalol is contraindicated in patients with poorly controlled asthma. As well, labetalol may cause neonatal bradycardia and hypoglycemia and should be used with caution in patients who are at risk for hypoglycemia, as it can further blunt hypoglycemia awareness. Nifedipine XL can be started at 30 milligrams daily and increased as needed up to 60 milligrams every 12 hours. It is contraindicated in severe aortic stenosis. As well, it is important to note this is a long-acting formulation and should not be confused with the short-acting form, which we will discuss in a later slide. Methyl-dopa can be started at 250 mg TID and increased up to 750 mg TID. This medication, however, may cause maternal depression and rarely hemolytic anemia, so monitoring for this side effect is recommended. When evaluating a patient for a new diagnosis of chronic hypertension, it is important to consider secondary etiologies by performing a thorough history, physical exam, and sending some investigations. Specifically, it is important to entertain secondary causes such as renal disease by sending a creatinine and urinalysis, hyperaldosteronism by obtaining potassium level, and an ECG to look for LVH associated with long-standing untreated hypertension. A fasting glucose and/or an A1C is also recommended to screen for frequently associated prediabetes and diabetes. As patients with chronic hypertension are at increased risk for preeclampsia, obtaining baseline preeclampsia labs is helpful for future comparison if preeclampsia is later suspected. These labs include a CBC, creatinine level, ALT, and urine protein to creatinine ratio. Patients who have chronic hypertension can have good pregnancy outcomes. However, they are at a heightened risk of developing preeclampsia, with an approximate risk of 25% compared with 5 to 10% in primiparous patients. It is important to identify patients who are at increased risk for preeclampsia in order to offer counseling and preventative measures. The highest risk factors include a prior episode of preeclampsia, elevated body mass index of 30 or higher, pre-existing conditions such as chronic hypertension, pre-gestational diabetes, chronic kidney disease, and lupus or antiphospholipid antibody syndrome, as well as the use of assisted reproductive technologies. Moderate risk factors include prior placental abruption, prior stillbirth or prior fetal growth restriction, or maternal age above 40 years of age, nulliparity, and multifetal pregnancy. Preeclampsia generally presents in the second half of pregnancy. The etiology is not known, but abnormal placentation is considered to be at the origin. Once preeclampsia develops, diffuse endothelial damage and vasospasm ensues, leading to a multisystem disease that can lead to endothelial swelling, edema, microinfarctions, and microhemorrhages of affected organs. Here is a quick recap on the diagnosis of preeclampsia. When chronic hypertension is accompanied by new or worsening proteinuria or one or more adverse conditions, it is defined as chronic hypertension with superimposed preeclampsia. Preeclampsia has the same blood pressure criteria as gestational hypertension, with a systolic of 140 or higher or a diastolic of 90 or higher. However, proteinuria or one or more adverse conditions are required to make the diagnosis. The adverse conditions include severe headaches or visual symptoms, chest pain or dyspnea, oxygen desaturation below 97%, low platelets, elevated creatinine, right upper quadrant or epigastric pain, elevated AST and ALT, atypical non-stress test or cardiotocography, fetal growth restriction, oligohydramnios, absent or reversed end diastolic flow by umbilical artery Doppler velocimetry, or angiogenic imbalance. When preeclampsia is suspected, the recommended workup includes a CBC, ALT, creatinine, and urine protein to creatinine ratio. Angiogenic markers can be considered if available when there is diagnostic dilemma. Measuring uric acid does not add to the diagnosis and is not routinely recommended. For surveillance in patients with grumbling preeclampsia, in addition to close clinical follow-up, periodic monitoring with CBC, ALT, and creatinine is recommended. Repeating urine protein to creatinine ratio is not necessary if the value has already reached the diagnostic threshold for preeclampsia. When patients have low platelets and elevated liver enzymes, HELP syndrome or hemolysis with elevated liver enzymes and low platelets is suspected. However, there may be additional diagnostic considerations in ill patients, and sending a full liver and coagulation panel should be considered in these cases with a thorough clinical assessment. Close fetal monitoring by obstetrics is recommended, where a number of tests can be obtained depending on the clinical scenario, including non-stress tests, biophysical profiles, serial growth assessments, umbilical artery and ductus venosus, as well as middle cerebral artery Dopplers. Proteinuria is considered to be significant when the urine protein to creatinine ratio is 30 milligrams per millimole or more, or the 24-hour urine collection is 0.3 grams per day or more. The NICE UK 2019 guidelines have an albumin to creatinine ratio of 8 milligrams per millimole as a threshold, although we generally use urine PCR in Canada. In multiple gestations, urine PCR of 40 milligrams per millimole is needed. Once significant proteinuria is confirmed, repeating to reassess the level of proteinuria is not required. We saw earlier the multiple adverse conditions that may be present and make a diagnosis of preeclampsia. When these conditions are present, close monitoring is recommended. Prompt delivery, regardless of gestational age, is required for the following circumstances: eclampsia, posterior reversible encephalopathy syndrome or PRES, cortical blindness or retinal detachment, a Glasgow Coma score or GCS of less than 13, transient ischemic attack or TIA, stroke or reversible ischemic neurologic deficit or RIND, uncontrolled severe hypertension over 12 hours despite 3 antihypertensive agents, oxygen desaturation below 90%, the need for 50% oxygen supplementation or more, intubation, pulmonary edema, platelet count of less than 50, transfusion of any blood products, acute kidney injury with creatinine above 150 without prior renal disease, any new indication for dialysis, hepatic dysfunction with INR above 2 without disseminated intravascular coagulation, hepatic hematoma or rupture, abruption or evidence of maternal or fetal compromise, absent or reverse ductus venosus, A-wave by Doppler velocimetry, and intrauterine fetal demise. The definitive treatment of preeclampsia is delivery. When preeclampsia is diagnosed, it is always in the mother's interest to deliver. However, this is carefully weighed with the fetal immaturity and fetal benefit of delaying birth. If a delay in delivery is considered safe, the mother and fetus are carefully monitored. In the 2009 Lancet HYPOTAT-1 trial, patients with gestational hypertension and mild preeclampsia were randomized at 36 weeks gestation to initiation of delivery versus expectant management. Those in the intervention arm showed improved maternal outcomes, and there was no increase in cesarean section or neonatal morbidity. This study led to the recommendation of initiating delivery at 37 weeks gestation in this patient population. In the 2015 Lancet HYPOTAT-2 trial, those with gestational hypertension and mild preeclampsia between 34 and 36 plus 6 weeks gestation were randomized to immediate delivery versus expectant management. The intervention arm found a reduction in severe maternal disease. However, there was an increase in neonatal respiratory distress syndrome. The balance between these two studies favors expectant management between 34 and 36 plus 6 weeks gestation. Taken together, those with hypertensive disorders of pregnancy not yet delivered by 37 weeks gestation should be offered delivery. For women with chronic hypertension without superimposed preeclampsia, expectant management beyond 37 weeks is recommended, and although initiation of delivery can be offered at 38 to 39 weeks gestation, it is more strongly advised at 40 weeks to avoid a later delivery. Treatments include magnesium sulfate, bolus, and infusion based on the MAGPIE trial. This is recommended to prevent eclampsia or seizures. Magnesium may also prevent cerebral palsy in preterm babies. Corticosteroids for fetal lung maturation should be given before 34 weeks gestation if premature delivery is anticipated. The blood pressure should be kept below 160/110 to protect the maternal brain from cerebral events such as stroke. The blood pressure target is usually less than 140/90, with some exceptions. When preeclampsia is diagnosed, limiting intravenous fluids to prevent pulmonary edema is recommended. Careful monitoring of the clinical status and labs is recommended as well. Severe hypertension is defined as systolic blood pressure of 160 or higher and/or a diastolic of 110 or higher, repeated within 15 minutes, and this severe hypertension episode should be treated urgently within 60 minutes of presentation. The urgency is highlighted given the increased risk of stroke at a blood pressure of 160/110 or higher. The options for initial therapy include IV labetalol, IV hydralazine, and short-acting oral nifedipine. Although oral labetalol and oral methyldopa appear on the list of agents recommended by the SOGC for urgent control, onset of action may be delayed and neither is used as a first choice at our centers. Of note, magnesium sulfate is not an effective antihypertensive agent. Continuous fetal monitoring is advised until the blood pressure has stabilized. This table indicates the initial dose and the recommended time for the next dosing if the blood pressure lowering effect is not achieved with the previous dosage. For example, when IV labetalol is used, if the blood pressure is not lowered to target at 30 minutes, then doubling the dose is recommended every 30 minutes until the desired blood pressure is achieved. For short-acting nifedipine, if 5 to 10 milligrams has not taken effect by 30 minutes, a 10 milligram dose is recommended. It is important to remember that in parallel to the urgent control, a more lasting control is needed, and a long-acting treatment plan should also be considered to allow for sustained blood pressure control. Although most patients with preeclampsia present antepartum, up to 25% of patients will present with hypertension in the postpartum period and may present with severe hypertension range preeclampsia. Although in the immediate postpartum, the blood pressure usually shows a transient reduction, this is usually followed by a rise in blood pressure between 3 and 7 days postpartum. For this reason, patients with hypertensive disorders of pregnancy should be counseled to continue checking their blood pressure closely throughout the first 2 weeks postpartum and counseled on where to seek medical care should their blood pressure control become suboptimal. The medications used during pregnancy can be continued postpartum and are compatible with breastfeeding. Additionally, ACE inhibitors such as enalapril and captopril can be safely used in breastfeeding moms. It may take up to 3 months for the blood pressure to normalize postpartum, and proteinuria may take up to 1 year to fully recover. It is important to ensure normalization of blood pressure and lab abnormalities, including proteinuria, as rarely an underlying renal disorder may be uncovered if proteinuria persists beyond the 1-year mark. This graph from the Van Oostard AJOG 2015 individual patient data meta-analysis shows that the earlier the preeclampsia diagnosis in the index pregnancy is, the higher the risk of developing preeclampsia in a subsequent pregnancy. However, although the risk of recurrence is high, the recurrent episode generally occurs later in pregnancy compared with the index pregnancy. For example, if a woman develops preeclampsia and delivers before 28 weeks gestation, her risk of preeclampsia in a future pregnancy is around 40%. However, there is only approximately a 4% risk of delivering before 28 weeks in a subsequent pregnancy. This data can be reassuring for women who are considering a second pregnancy but have had such a severe early onset preeclampsia episode. Given the significant repercussions of preeclampsia, a careful assessment of preeclampsia risk should ideally be done preconception or in early pregnancy. Women who are at higher risk, as seen earlier in more detail, including those with a prior episode of preeclampsia, chronic hypertension, pre-existing diabetes, and chronic kidney disease, should be offered preventative counseling and treatment. Low-dose aspirin between 81 and 162 milligrams nightly is recommended and should be started prior to 16 weeks gestation, although this can be started around the 10 to 12 week mark in most patients at higher risk, with some exceptions. If insufficient calcium intake, supplementation with calcium is recommended. In addition, regular aerobic activity prior to and during pregnancy is recommended to reduce the risk of preeclampsia. Avoiding excess gestational weight gain may be protective as well. In general, for all women preparing for pregnancy, taking a folate-containing multivitamin, smoking cessation, abstinence of alcohol and drugs, and regular physical activities should be recommended to all women. Given the endothelial damage caused by the preeclamptic state, there is accelerated vascular aging that ensues and leads to increased risk of cardiovascular events in these women. Women at greatest risk are those who had early onset preeclampsia, stillbirth from preeclampsia, or placental abruption. It is imperative that these women get counseling to improve their cardiovascular health, including counseling around weight management and regaining pre-pregnancy weight within 1 year, and any other sustainable weight management based on BMI, physical activity, 150 minutes per week, and targeted risk factor management such as smoking cessation, hypertension management, dyslipidemia, and diabetes management. As well, for future pregnancy planning, lifestyle management is recommended, as is spacing pregnancy by 18 to 24 months. Please find a list of resources that may be of use to you for your further learning. We hope you've enjoyed this module.